Debdatta.
Yeah, good evening. Good evening.
Yeah, you can start.
Okay. So,
AFib, ACS, AFib, ACS, and antiplatelets.
yes. So, my warm regards to all the seniors who are present here, with special regards to my mentor for the last 20 years, Professor Santanu. And thanks, Dr. Sir, for giving me this opportunity, at least to be a part of this luminaries. It's really an honor for me. I would not waste time. I would just quickly want to share my slides if you allow. So, sir, as you said, my task is a cut down, that is antiplatelets in acute coronary syndrome on a background of atrial fibrillation, which essentially means that the patient is really on a oral anticoagulant therapy, either less likely a VKA in today's date or more likely a NOAC. So my job would be to maybe juggle with these agents, 3 of them in total, and see how to go about it. Yeah, so as we all know, realize that entire talk, the intent of discussing all this is simply to maximize the thrombotic protection. And we are speaking of thrombotic protection in the intracranial vessels, not only, but also in the coronaries. So double thrombotic protection in that sense, and certainly to minimize bleed. See, we have all understood that bleeding is the spoil sport here. In spite of all our efforts, if the patient really bleeds, then all our efforts really goes in vain. So these are the 2 goals based on which we would have to shape our therapy. Yeah, so I thought I would, talk on these following headings, that if a patient of NSTEMI comes to me, and obviously, let me reiterate, it's well known that the background is oral anticoagulant therapy. So a patient of STEMI lands up with me, and if we can conservatively manage, how do we go about it? If we are invasively managing the patient, how do we go about it as regards to the antiplatelets and the oral anticoagulants? And the same principle for the STEMI patients as well. Even as we speak today, most patients of ACS would be really managed by the conservative therapy, and very few really fortunate people would have an opportunity to be managed invasively, even as we speak today, and regardless of what the guidelines say. So I thought I would enlist a few of the key principles which guides the therapy and helps us understand how do we handle these 3 drugs. I put it as STAT, as we know, triple antithrombotic therapy. How do we handle that? So it's obvious that we all do it in our day-to-day practice, assess the ischemic risk as well as it's a delicate balance between the 2. We always said, what is the ischemic risk of the patient and what is the bleeding risk of the patient? So the ischemic risk, obviously the commonest score that we are still all use is the STAT-VASc score. And the other 2 bleeding scores that we use, and again, as we speak, HAS-BLED is the commonest score that we employ for assessing bleeding. It's said that the ABC, scores ahead of HAS-BLED, but I have personally no experience on this. Age, biomarkers, and clinical history of bleeding as far as this score is concerned, we are all happy with HAS-BLED. And obviously to focus on the modifiable risk factors, both in the ischemic scoring as well as more importantly in the bleeding scoring, like abnormal liver and renal function, labile INR, those points, drugs, alcohol. If the intent is very clear, try and reduce bleeding risk as much as possible. Triple therapy duration as short as possible. We'll discuss that. Oral, whenever we are using an oral anticoagulant, the default antiplatelet, P2Y12 would be clopidogrel. In all patients, consider NOACs, excepting in mechanical prosthesis and severe MS. Otherwise, it's all NOAC, and there's no hindrance of cost anymore as far as NOACs are concerned. Consider a very importantly, target INR should be towards the lower range of normal. If it's 2 to 3, we would love to keep it at 2. If it's 2.5 to 3.5, we would love to keep it at 2.5. And the TTR would be ideally more than 65 to 70. Again, a very important point. Consider the lower NOAC regimen as has been approved in stroke thromboprophylaxis. We will speak of that also. Clopidogrel, I said, is the P2Y12 of choice as far as concomitant therapy with OAC is concerned. Use a low dose of aspirin. 75 milligrams is enough for all patients, and more so when patients are really on OAC. And for gastroprotection, we all do routinely use PPIs. Yeah, so if we've identified those principles, it's also imperative that we identify who are the high thrombotic risks patients. So obviously, patients who have already had a stent thrombus on adequate antiplatelet therapy goes without saying. Stenting of the last remaining vessel, diffuse multivessel disease, CKD, is a risk factor for both, thrombus as well as a bleed. 3 stents at least implanted, more than 3 lesions treated, bifurcation, CTO, total stent length more than 60. It's very important that we remember all these points. It's well known to all of us so that we can manage the TAT versus DAT likewise. So I thought I would quickly, this is the recent guideline, as we are all aware, ESC NSTEMI guideline 2020. I'm not here to read all of them again, want of time. I thought I would just underline few of these very important points, and that is discontinuation of antiplatelet, mind you, in patients treated with an OAC after 1 year. This is something which even I fail to digest and maybe employ in my practice. I would have the opinion of the August gathering here. Are we confident enough to completely withdraw antiplatelets after 1 year? Mind you, in an ACS patient who've already been stented. Another point I wanted to highlight here was, had bled more than 3, then Rivaroxaban would be 50 and Dabi would be 110. Apixi would be in the same dose, that is 5 milligrams. So lowering the dose of NOAC, as we mentioned. And another point I wanted to highlight was DAT, 1 antiplatelet and 1 oral anticoagulant in medically managed patients of NSTEMI post 1 year. I know, and so I would, I know there's a lack of time as always. So I thought I would speak on these few lines. STEMI conservative management, loading would be aspirin 150 ideally rather than that. Clopidogrel we've already mentioned. This is very important. UFH is the anticoagulant of choice, and the dose is also important. Rather than 70 to 100, we would want to have it at 60. Refrain giving any parenteral anticoagulation if the INR is more than 2.5 is also important. And we would love to have a fibrin specific agent as the lytic of choice. Having said that, it is so important to realize that more so in patients having a background of an oral anticoagulant, we would all want to triage patients to primary PCI regardless of the time delay. So more so in here, because we know that oral anticoagulation is a contraindication to fibrinolytic therapy, but guideline is something, and the practical scenario is all completely different. But yes, if you are fortunate enough to go for a primary PCI, 600 milligrams would be the loading dose of clopidogrel. No other no other P2Y12. Parenteral anticoagulation as usual. Very important, and this I feel is even more important. Do not stop the chronic anticoagulation. Neither VKA nor the NOAC, even if you are giving a lower dose parenteral anticoagulation, is a point to reckon. Very, very important. And then, NSTEMI conservative, it's all the same. I would, again, for lack of time, it's the same story here. I thought what is more important here is NSTEMI invasive management. Very, very important, because unlike as what we had all done, that dual antiplatelet loading, it's not recommended here, only aspirin loading. If a patient, obviously an invasive strategy, do an angiogram, look for the coronary anatomy. If the coronary anatomy dictates it would go for a CABG patient, don't give the second P2Y12. If a patient goes for a PCI, only clopidogrel here, obviously, because you are on a OAC, but otherwise it would have been prasugrel, as we know, ahead of ticagrelor. Or parenteral anticoagulation do not stop is the same. This is the most important slide, and I think I'll spare me maybe 30 seconds time to discuss this. Maintenance depth in the NSTEMI, this is something very, very new and very important that we would love to, you have 3 category of patients where the ischemic and the bleeding risk is almost equivalent. That is the default strategy. High bleeding risk, we've already said the score, and high ischemic risk also we've discussed. So in all 3 categories, till the duration of hospital stay, aspirin would be there. So triple therapy, TAT, 1 OAC plus 2 antiplatelets, aspirin just for a week's time, and then continue with clopidogrel and oral anticoagulant up to 1 year in the default strategy. If obviously the bleeding risk is high, you reduce that duration of that to 6 months and continue NOAC alone. And if obviously the other end of the spectrum, if you have a high thrombotic risk, increase the TAT for 1 month and then up to 12 months, use a DAT in the sense is double antithrombin therapy. And this is the point of interest, that after a year, regardless of whatever you do, you don't have any antiplatelets here, much unlike what we still do. And maintenance DAT, yes, maybe a minor change from what we had in NSTEMI. Here, TAT would be for 3 to 6 months, depending on the ischemic, the bleeding risk, followed by DAT up to 1 year. TAT standing for triple antithrombotic therapy, and that is for dual. And again, the same, logic, OAC, oral anticoagulant after 1 year without any antiplatelet whatsoever in an ACS patient. I think I would end here. If the patient really is subjected to a CABG, we would just have the TAT for the duration of hospital stay and followed by DAT for 12 months, OAC alone, and it's the same throughout, regardless of what management we employ. I think it was a pleasure, right, to discuss such an important topic. There's always a want of time. Sincere thanks to all of you and my warm regards to all my seniors. Thank you.
Thank you, Dr. Dutta also. I mean, he has covered most of it, and except that the naming of the NOAC study, maybe I should do that, the Pioneer AF, the Redual PCI, the Augustus trial, and of course, finally, the Entrust AF-PCI, which is the last one, which also, in fact, was trying to show a superiority over the warfarin regime. And every one of them has shown that possibly the time has now come to decide on, in AF-PCI, better we will use a DOAC rather than the conventional warfarin. And as you rightly said, here the concept is less is more. So we will try to do away with the aspirin part, as the Augustus has shown us at the earliest. I will not say 1 week, but that's what the Augustus guys has done. That is one point. So keep it to the maximum of 1 month, then the 2 drugs, then finally after 1 year, just the anticoagulant. That's one. Then the next point, again, you mentioned that, see what will happen, even though conventionally it is clopidogrel and clopidogrel always that we are using. Augustus data showed at 12% of these patients being used ticagrelor. So at the time, possibly is going to tell us about the use of the newer newer, more potent antiplatelet drugs when in using with the DOACs or even warfarin. So these are the 2 important areas I foresee in the future in AF-PCI, which is not a very small group. Maybe about 10% or 12% of our patients had AF, and we are not forgetting another subgroup of DVT patients or somebody who had PE and then on oral anticoagulant. So we do definitely see patients who merits PCI in AF situation or anticoagulant situation.
Yeah, this is a very difficult group of patients because decision will depend on the trade-off between ischemia and hemorrhage.
Yeah, absolutely.
And you should remember 4 figures: 7 days, 1 month, 3 months, 6 months, 1 year. These are the different mileposts in terms of time when the antiplatelets may be reduced or maybe switched or maybe de-escalated.
But
And
one thing, yeah.
Sorry.
One thing, Dr. Majumdar, we should remember, Dr. Kahali here, that all patients of AFib, you know better than me, doesn't need, this oral anticoagulant. So some of them will do fine if their CHA2DS2-VASc score is low and doesn't qualify for OAC. So we should remember about that group also. So if we talk, then we have to talk that DAPT as usual, and in the group who needs OAC because their CHA2DS2-VASc score qualifies, then these things will come.
So
Yeah.
2 points.
Because all patients, all patients of AFib with PCI don't qualify for OAC.
If I can make a small point, if you
Sure.
2 points is just again because of lack of time, I couldn't mention the trials that Dr. Mohanan mentioned. That is point 2. As Dr. Kahali sir mentioned, that if a patient of AF really doesn't qualify for a OAC, then makes our job very easy. That certainly it's as good as a sinus rhythm as far as antiplatelets are concerned. So I actually wanted to highlight that oral anticoagulant part. And 3rd point, as Dr. Mohanan pointed out, again because of lack of time, that is, even though we are always speaking of clopidogrel in combination with the OAC, we are allowed to use prasugrel or ticagrelor as a part of DAT, not TAT, as a class 2B indication in patients where we can understand whether ischemic burden is extremely high and the bleeding risk is acceptable. So not that it's completely out of the scenario in a combination of OAC, prasu or tica can be used, but yes, it is a class 2B as of now. Thank you, sir.
And most importantly, a patient of atrial fibrillation having acute coronary syndrome itself is probably, along with its risk factors, increases the risk score from 2 or above. So it is very rare, very infrequent, very unlikely that an atrial fibrillation patient with ACS will have a CHA2DS2-VASc score less than 2. But if it is there in rare situation, as Dr. Dhiman Kahali pointed out, then obviously we should go accordingly. And the
VASc itself is an acute coronary syndrome is a VASc.
That's I say. It may, particularly in case of female or male. In any case, it is very, very, very rare that we can get below 2.
How's Debabrata start?
Yeah, just a minute. I just want to make one point that there has been a number of meta-analyses where they have reiterated the fact that going by the guidelines, reducing the DAPT too early may result in increased number of stent thrombosis and MI. And there are reports that if necessary, you continue the DAPT along with oral anticoagulant for up to 6 months or 3 months, depending on the risk of ischemia and hemorrhage, particularly in high risk burden patients, as the Debabrata Majumdar pointed out at the initial stage. That is very important.